and she is still active at this point in teaching persons who want to better their lives to become nursing assistants and so on. And also she is like a life coach. She gives a lot of young people advice. She also helps them and guides them. She's adopted me as well as one of her own. And on top of all of that, she is also one of the founding members of the Grenada Patient Kidney Foundation. So she is well versed in many, many areas, especially when it comes to dialysis in Grenada. She has probably seen it all. So that is Miss Ann Hopkins for you. So.
Thank you, Daniel.
Thank you so much for that. Good evening, Miss Hopkins. How are you?
I'm very well, thank you. And how are you?
I am humbled to have you on the show, first and foremost, all those accolades there. So I have many questions to ask you.
Thank you. I'll try my best.
Okay, so Daniel says that you were one of the founding members of the Grenada Kidney Foundation. So what was the intention of the Kidney Foundation when you first started off many years ago?
Well, I didn't really start it. I came when it was just started.
Okay.
But the goal was to educate about kidney diseases, prevention, and when you have a kidney problem, how it's treated, how you should go to the doctor, and how you should take care of yourself. Educate the children in their nutrition, in their diet, because as we know, obesity, high blood pressure in children, and diabetes are the causes of kidney failure. So we try to push the children in the right direction in their diet and what they eat and what they should not eat, including exercise and rest. We try to go to the schools to educate, churches, educate, PTs and educate, and also into the communities.
Do you feel through the years that your message has been heard in terms of healthy eating and changing of lifestyle, despite the West Indian way to eat all sorts of food that may not be in the best interest of the individual that's eating it?
I think right now, people is getting very conscious of the exercise and diet. But I think we have a long way to go, because I can still see mothers feeding children Coke in a bottle, infant. I can see them with all these foods, fried foods and fried potatoes. I wouldn't even to call names, but I'm still, and anyone who I see, I try to educate and tell them this is not the way to go, because your kidneys are irreplaceable. And the cost for maintaining you when you do not have a functioning kidneys is enormous. So we try to do our best, but I don't think the heeding of the education is there are some people is taking it very well and passing it on to their family, but some again, most people are not.
Do you think tradition rules over sensibility and healthcare?
I think so. And I think this is where knowledge, education from the school comes in, because habits is very hard to break. Habits. Once you have formulated an habit, it is very difficult. You have to put a lot of effort. You got to say to yourself, is it beneficial to me or not? But still, we always try, we're going to go routine, we're going to eat a large amount of carbohydrates and less amount of protein. And I think in most cases, almost tradition plays a very important part in our lifestyle.
So what are the typical foods we're talking about here that would cause one to have kidney failure or issues with their kidneys through diet, which is not helpful to it?
It's not the food on its own. We have bananas, yams, sweet potatoes, dashings, very starchy. But it's not the food itself, but it's the amount that we eat.
Okay.
It's not the food itself. The food is very good, but we have to know the amount we should eat in order to maintain good health.
So where's the balance between the amount of food you're meant to eat and being a glutton? Where is that? Because for each person, there's a different amount of money, different amount of food to be eating, money,
Yes.
different amount of food to be eating, depending on the person's size, weight, height, build, you know. So where's the fine line? Where's the balance?
Well, they are saying, do not eat till you feel overfull. Eat when you are satisfied. Stop when you are satisfied. Do not eat say, oh, I'm failed, I don't know what to do. Do not go that way. Go when you're satisfied. Stop when you're satisfied.
But where does the mentality, do you believe, come from eating to the point where your belly is almost close to exploding? Where do you think that mentality comes from?
I don't know. I think that mentality was from the beginning, because we had from the beginning of creation, we have a lot of glutton people. Look at Eve. Eve did not have to eat the fruit, but she did went and ate it.
But Ms. Hopkins, I'm sure you would agree that modeling behavior, if children are watching their adults with behavior which is not healthy, then all that's going to happen is the children are going to get older and continue that cycle of unhealthy eating. So how do people on the island of Grenada, not just the island of Grenada, but across the Caribbean and the diaspora, how do they go about changing the cycle of what we have at the moment and breaking that cycle to now have healthy options?
Nutritional education starting in school, and children usually bring things home to the parents. So nutrition in school, nutritional education plays a very important part. And we go to the PTA's meeting and we're trying to let people know that the amount of food, we give them the size of the plate and what should be on the plate. And telling them again, do not eat when you overeat, just eat when you are satisfied. And the quality of food, not a lot of provision, and you don't have protein, and you don't have vegetables, and you don't have a salad. No, portion your plates.
But if this is part of, is this part of the national curriculum? If not, why not? And if it's part of the national curriculum, how effective do you think that message is getting through to the young people from primary school to secondary school to being in college?
I think right now we have nutrition in school. The nutrition, the nutritionists go into the school to educate. So it will take some time, but in future, I do think that the children, the younger children that is growing up now, will tend to have a better eating habit, a better nutritional values. Everything is values. What are your values? And even nutrition, sleeping, what are your values? In learning, what are your values? So I think everything is based on the values. And if we have good values in the home, the children will grow up with good values. And if we have bad values, the children may grow up with bad values. This is why our function is a hard task, very hard task, because it's a very small amount of us, very hard task, but we are trying our best to bring nutritional values in the home. And I am at the television and the radios very often with eating, nutrition, and the food that should be eaten and not eaten. Every month, I'm on a program with nutrition for the community of Grenada, Carriacou, and Petit Martinique.
Now, values is a very, very, very important point. But what about beliefs and convictions? Because surely the greatest challenge of all is the global belief. The belief on the conviction a person has that this is good for me, this is right. So a value is one thing. Well, you know what? I value food. But the belief that, you know what, I must eat till my belly's full. I must eat this food because it's cultural, because it's traditional, because this is the way it is. That's a belief. That's a conviction. And if you can't tackle that belief system, that conviction, and that's the hardest thing to break. If we can break that conviction system, that whole belief system, and say, well, you know what, I should eat in moderation. You know, I should eat because I want to live a longer life, and have that as our belief system, then maybe our values may change with that as well. What are your thoughts on that?
Yes, because you are quite right. Because in teaching, you have to bring into the fact the disease that can be caused by obesity, and obesity can lead to high blood pressure. Obesity can lead to diabetes. So we have to bring this into the fact, into the equation, to let people know the outcome of eating gluttonous, eating too much. The outcome can be life-threatening. Do you want to live a long life? Do you want to live a healthy life? Or do you want to live a life in problem all the time? The outcome of kidney disease is what are the outcome. So this is why we have to try to break. It's very hard. It's very hard, but that's why we have to try to break that system from school and PTs and the communities. And I think a lot of people is doing much more exercising now. And a lot of people is eating a lot of salads right now. A lot of people. I noticed that about 2 or 3 years ago, Daniel. I don't know if you noticed that too. Most people are trying to eat better 2 or 3 years ago. I can see when I go to the supermarket, instead of all these Concords and all these potato chips and all these things, they're having more fruits and vegetables in the baskets.
Daniel, I was going to bring you in right here because I think it's a perfect moment to bring you in, because you, as well as Ms. Hopkins, on the other side, you get to see the patients that come in and have to be treated because, unfortunately, their kidney is not working the way as would have hoped to be working, and then they have to come and see you and Ms. Hopkins at the Kidney Foundation. Talk to me on the other side of things. You're receiving these patients, you're dealing with these patients. What does that look like from your perspective? And this conversation, how it relates to that.
Okay. So yes. So as Ms. Hopkins was rightly saying, that a lot of the contribution or the reasons behind kidney disease or kidney failure can come into light with diet and habits, lifestyle. Most of the patients that I have, or that we have, I should say rather, they all are. Well, most of them are related to hypertension and diabetes. And we know that both hypertension and diabetes in most cases are due to lifestyle, right? So unfortunately, those 2 lifestyle diseases are major contributors towards kidney disease and kidney failure. On top of that, now that the persons are now, their kidneys have now failed, it even puts, well, it puts a further strain on patients now that they are forced into eating the right way. And it's not a matter of eating the right way to bring function back, but it's eating the right way now to stay alive. And as we continue, we will basically discuss some of the reasons as to why a dialysis patient's diet is so important if they wish to continue living, especially when it comes to things like the compounds that they eat, which are crucial for the function of their body, but at the same time, too much or too little of certain things can cause them to have severe complications that can lead to fatality. So it is a challenge for us, maintaining diet, and especially breaking people out of the habit for so many years of eating whatever they feel or whatever their mind tells them to, eating in immoderate amounts or eating excessively, only to then have to tell them that they have to change. And it's so difficult. I mean, when you tell patients that, you know, no more mangoes, no more bananas, no more oranges, no more ice cream, no more milk, I mean, they go crazy. It's like, well, what do you want me to eat, grass? But it is a mindset that we have to try to learn to break. And the idea of having the Kidney Foundation set up is to break that mentality, to prevent those things before they occur. And as we say, a stitch in time saves 9. You were asking for an idea of, is the eating cultural, or how should we curb that, or what should we use? I usually like to say that we eat to live and not live to eat. I think that's the best nutshell I can put it in.
Yes.
That you eat to live, not live to eat, basically.
I see Ms. Hopkins there, you're nodding your head there in agreement.
I do agree. I do agree. We think that we have to eat. We have to eat. We must eat. You know, but what are we eating? What are we eating? We eat between meals and we eat junk between meals, and we're trying to break that mindset. I'm trying to see before I demise, before I leave this earth, that a lot of changes has taken place with our people in Grenada, Carriacou, and Petit Martinique. I also do go to Carriacou and Petit Martinique and look after people with the disabled, and also do a lot of teaching in diet, because I'm passionate about health. I'm 83 years old and I'm functioning, I'm teaching, you know, so I want to bring that, my example, to our fellow Grenadians, to let them know that, you know, my plate is very small. I'm satisfied. I'm 100 and maybe 30 pounds, you know, and they say as you get older, you get fatter, but no, food, except you have a glandular problem, except you have a medical problem, but food do increase your weight.
Amen. Amen. Daniel, I want you to really, you were talking about fatality, and sometimes when people realize the seriousness of the matter, and you know, this is no game, this can happen to anybody. When people realize the seriousness of the matter, and when you talk about fatality and death, people seem to go, away. Whoa, hold on a second. So tell me the effects of reckless eating and how that affects the kidneys and the symptoms, and then from that, how the kidneys fail and how a patient then comes to you.
Okay, so let me see if I can just share a few of what I have. Let's see if I can, 1 second. Let me see if I could probably try sharing it, and let's see what happens there.
All right. Share screen. Can you share screen?
Yeah, I'm going to try. Yeah, let me see if I can do that. And allow.
Yeah,
right.
And then I'll bring this up on my screen. How should we bring it up here?
Right. So
Bang.
I'm going to
get that. Can we get that zoomed in?
Yeah. So let's see if we can get that done.
Oh, it's not sharing your screen, sharing a screen. Yeah, okay. There we go.
Is that good?
Yes, good, but I'm not seeing anything yet.
Okay. What are you seeing right now? Nothing at all?
No, share. I'm seeing my screen, but I'm not seeing anything else.
Okay, okay. Let's see if we can do that again. All right. All right. So
Can we try again?
Yeah, I'll try again. And let's see if I
waiting for you to change the screen, Miss Hopkins. Melvin Catane from the Olive Branch Project says you could only give what you have. Too much fast food and GMO food, costs of living is too high. Do you respond to that?
Can you repeat it?
Master Melvin Catane from the Olive Branch Project in Grenada says you can only give what you have. Too much fast food and GMO food, costs of living is too high.
Yes, this is why we should eat what we grow
Unmute.
and grow what we do it, because the cost of living is.
No, Miss Hopkins, not you. There you go. I think you've muted yourself, Miss Hopkins. You've muted yourself, Miss Hopkins.
Unmute.
Go ahead. Repeat what you're saying, please.
I said this is why it's important that we grow our own food and eat our own food, because all this food that are having all these hormones and having all these things added onto it is not good for our body. It's not good. So this is why we should eat the food we grow and grow as much food as we can.
Master Melvin Coutain continues by saying, this is what my class is teaching, Ingram. People living paycheck to paycheck and overtaxing people how they're buying food. Miss Hopkins?
Yes.
Did you hear that?
No, repeat this. I thought you were speaking to...
Oh, Master
Daniel.
Melville says, this is what my class is teaching, Ingram. People living paycheck to paycheck and overtaxing people how they buying food.
Yes, because the tax on food is very high. I think you do have to pay tax on food, and this is extremely high. And we do live from paycheck to paycheck because of the cost of living for food is extremely high. And if you're working for $700 a month, how can you really buy? And you have 3 children, 4 children. How can you really buy nutritional food with nutrition? How can you manage that? Except you really teach yourself that it doesn't matter how much I have, I'm going to try to use, buy my food or grow my food, or I use things which is very nutritional. It may be more expensive, but yet it's worthwhile because this is nutritious to my body.
Let me see if I can bring this up here for Daniel. Okay, see that? There is a screen there.
Right.
Bring this screen up big. Can you get that screen big?
Sure.
You bring that up so we can.
Yes.
Fantastic. Let me see if I can bring that screen up bigger. Let's see if I can do this here.
Yeah, that's it.
Oh, yeah.
There we go, Daniel.
Right.
Go ahead.
Go ahead and mute. Right. So as you were asking in regards to lifestyle and how can the complication of your diet come into play with kidney disease? There's several lists of things that can cause kidney disease, but I'm just going to read for you here, which is the 2 major causes here. All right. So the most common causes of chronic kidney renal failure in North America are diabetes mellitus type 1 and 2 and high blood pressure. Now remember I had mentioned earlier that these 2, for the most part, I'm not saying exclusively, but for the most part, they are lifestyle diseases. So these are the most common causes of end-stage renal failure worldwide, right? Diabetes and hypertension both cause damage of the small vessels throughout the body, including the kidney. And I'm just going to show you a quick diagram here of how the kidneys operate. Now, this is just a diagram. I hope you can see, but if you look to the top right-hand side, you have those 3 steps there on how the kidneys filter or clean your blood. So it says that the blood flows through the kidney at high pressure in the cortex, which helps to force the small molecules through the walls of the tubules. Water, sodium, and essential salts, glucose, amino acids are reabsorbed into the blood. And then 3, the loop of Henle is is concerned with the reabsorption of water and the maintenance of acid-alkaline balance, and then unwanted salts, urea, and water leave through the urine. Now, if you look at the bottom right, you notice that there is an indication that says blood vessel, and there's something that says proximal tubule. So there's one that's red, and then there's one that's yellow. Now, this red vessel here, it's basically what you'll call the glomerulus, right? And they are microscopic vessels that run into the center of your kidneys. They come very close to what we call the Bowman's capsule. And like we said, and it was mentioned earlier, through some of the pressure as well as diffusion and osmosis, the kidneys can pull unwanted things from the blood into those tubules. Now, the biggest problem that high blood pressure and diabetes causes is that tiny microscopic blood vessel, too much high blood pressure, or I should say uncontrolled high blood pressure, can cause these tiny tubules or blood vessels to be damaged because they are not made to withstand consistent high blood pressure. So what happens is that they swell, they move, they expand, trying to accommodate for the high pressure that comes in, but then that causes scarring within the tubules. So once that causes scarring within the tubules, I should say within the blood vessels, each scar or each reoccurring scar creates a blockade for the blood to pass, till eventually there's so much damage to those vessels that the blood can no longer freely flow through those vessels, therefore impeding the ability of the kidney to filter the blood. Likewise, with high, I should say, diabetes or high glucose levels in your body on a prolonged, consistent basis, studies and science have also shown us that the diabetes as well causes damage to blood vessels throughout your body, especially the microscopic blood vessels. This is why a telltale sign for somebody who is diabetic is that sometimes if you look at their feet and you notice that their feet is damaged, or if somebody is diabetic and they get an injury, the injury takes a very long time to heal. Why is that? Because diabetes is now restricting and preventing the flow of blood through these microscopic blood vessels. So this is why we go back to diet and lifestyle, that if you can prevent it, you can prevent the damage, or you can, if you change your lifestyle habits, you can prevent the damage that can occur. Because the high blood pressure and the diabetes, you can't tell which part of your body is going to destroy first. It probably might destroy your kidneys, probably might not. It might destroy maybe the cause macular degeneration in the back of your eye, or something else. So you don't really know where. So you don't want to take the chance. And now is the time to change our lifestyle.
Wow, that's incredible.
Can I add something? And we have to remember also compliance with your medication and diet is extremely important. As my friend said, Daniel said, the complication caused by high blood pressure and sugar. And one thing we notice in the new research, that when your sugar is high, constantly high, it in your kidneys, it clogs the tubules and the vessels. It's like wet sugar. You see when sugar starts melting? That's how it looks, like granules, and it clogs these blood vessels. So therefore, if you keep your blood sugar at a minimal, under 120 and under, then these aggregates do not form in the tubules, and especially in the loop of Henle, which is very important, and also in the Bowman capsules, because the Bowman capsules is where the filtrate occurs. And if the Bowman capsules is like a sifter, you know, like a sifter that you put, when you have to sift, like you make juice, and you have to pour it through the sifter, what stays, you throw that away. But in the kidneys, everything passes out, because therefore you cannot do the right functioning. So therefore, with diabetes and high blood pressure, you have to be compliant to prevent the aggregates of the sugar clumping the blood vessels, and especially in the Bowman capsules.
Wow. Did you have more information for us, Daniel, or was that it?
Well, yeah, I do have quite a bit more information that we can discuss. Since we're dealing with a lot in regards to diet, so I'm just going to shift over into that aspect of the presentation that I have here, and we're going to speak about a few things in regards to when you do have renal failure, what exactly is needed. But before I do that, I'm just going to show you what a healthy kidney looks like, just for reference, for those viewers who are there. All right, so I don't want to show you that one as yet. I wanted to show you more of a healthy looking kidney. I should have one somewhere in my presentation. Right, there you go. So if you look at this here, this is what down into your bottom right hand corner, this is what basically a healthy looking kidney should look like. I'm sorry if anybody's a little squeamish, but if you look at it, that's where kidney beans got their name from.
I was about to say, that's where kidney beans got the name from. I get it now.
They look just like a kidney. The kidney beans look just like a kidney, right? As you can see here, the three major roles that the kidneys play are to remove waste from the body, to produce hormones that control other functions, such as regulating blood pressure and producing red blood cells, and also to regulate the level of minerals or electrolytes like sodium, calcium, potassium, and fluid within your body. Now I'm going to show you what a damage, and also your position of your kidneys. They lie to your back. All right, so they lie to the back of your body, just below your rib cage, and they actually sit one slightly higher than the next. So if you're wondering where your kidneys are, they're actually to your back. And this is also a note for others that injuries to your back or to your lower back can cause acute or even long-term damage of your kidneys. So if it is that you did get a fall, or you got a hard blow, or you've been in an accident and you may have damaged or hit your lower back, please get it checked out to make sure that you haven't injured them and they're fine. There are blood tests that you can do to make sure that, also urine tests to make sure that you haven't damaged your kidneys too much. All right, so I'm going to show you now what a diseased kidney can look like to some extent. This is actually a kidney here, two kidneys of a patient to your bottom right there, and that's actually a disease called polycystic kidney disease. There are several cysts that grow on the kidney, and that damages the kidney every time they grow, and they grow into the kidney and they burst and they cause scarring and they actually destroy the kidney. However, polycystic kidney disease is what we will call a hereditary disease. It is something that is passed on through genes or genetics. And if one of your parents have it, you stand roughly about a 50% chance or greater of receiving or actually inheriting this disease, right? So let's go on to, we're speaking about diet, right? Nutritional consideration. So let's go through some of these here, and just to get persons who are viewing an understanding. So people with compromised kidney function must adhere to a renal diet to cut down on the amount of waste that is in their blood. The waste in the blood comes from food and liquids that are consumed. Now, we have to understand that we're not consuming waste, but anything that becomes unnecessary becomes waste. So you may have a nice big plate of food, but after consuming that, the body is only going to take what it needs. It's not going to take more than it needs, after which everything else becomes waste, right? So when the kidney function is compromised, it does not filter and remove waste properly. If the waste, however, is left in the blood, it can be negatively affect patients' electrolytes. Following a kidney diet may also help promote kidney function and slow the progression of complete kidney failure. And I want us to just touch on that topic just a little bit. Now, we spoke about the fact that kidney failure, diet, things like that, you try to avoid. Now, there are several stages of kidney failure. And the thing of how important diet is that any one of these stages except stage 5, you can, based on diet and lifestyle change, you can actually prevent progression or halt progression of kidney failure if you happen to be in any of the first 4 stages. So we have stage 1, where persons do not need renal dialysis, and that is where you see here GFR, which is the glomerular filtration rate. So that little diagram that I showed earlier, this is saying that this is 90% or more percentage of filtration, right? So you still have normal kidney function, you're still okay, nothing to really worry about, but it has to be monitored. When you go into stage 2, you would have mildly reduced kidney function, and there will be other findings that will show up, especially with blood, with your blood tests and so on that you will do. certain things like that will be happening. Stage 3, it starts where you have anywhere from 45 to 59%, or stage 3B, 30 to 44%, where you have moderately reduced kidney function. Now, as I mentioned, at any of these stages until stage 4, you can drastically change your diet and drastically change your lifestyle, adhere to the instructions of your health professional, adhere to your medication instructions, and you can actually stop yourself from progressing further, right? However, when you get to stage 5, which is 15% or less, the person has to start dialysis or they will die eventually. So we can use our diet to slow things down or to prevent, and this is what we are trying to advocate for. Now, bear in mind that if you notice the description of the different stages, everything says mild to moderate until you almost reach to stage 4. And this is one of the tricky things with kidney failure, is that it sneaks up on you. And most persons do not realize that they have kidney failure until it's already too late. So that puts another point out there that we should continue to do yearly checkups and ask your doctor to do a renal function test and other things like that, so that they can be compared over the years to make sure that you are not losing function or losing use of your kidney. So let's go. So here's 4 of the main things that renal patients need to stay away from moving forward. So we have phosphorus, we have a little salt shaker there for sodium, we have the element potassium, and also, well, not to stay away from, but an important role in kidney diet is protein. So the renal diet is one that is low sodium, low phosphorus, low in sodium and phosphorus, but usually sometimes it goes both ways, either high in protein or low in protein, but most of the times, sometimes it can go on to the higher side. The renal diet also promotes the most importance of consuming high quality proteins, as was mentioned. So we're not just going to eat any meat, we're going to eat healthy meats that have high biological value, as they would say, so that you can get the most out of it. Everybody's body is different, and therefore it's crucial that the renal dietitian works with each patient and comes up with a diet as it is tailored. So here's what sodium does. So sodium is one of the 3 major electrolytes. Potassium and chloride are the other 2, that controls fluid going in and out of your body, of your body's tissues and cells. It contributes to regulating of the blood pressure and volume. It helps regulating nerve function and muscle contraction. It regulates the acid-base balance in your blood, and it also balances how much fluid the body keeps or eliminates. Now, the reason why we need to reduce sodium in the body, because as mentioned, that depends on how much it keeps or how much it releases. We know that salt likes water, right? If your kidneys are not functioning properly, one of the main things is that you will have decreased fluid output. So you don't want to consume high levels of sodium so that the sodium is now attracting the water to itself and keeping it there. So we have where too much sodium can cause to be harmful in patients with kidney disease, because they cannot eliminate the excess sodium and fluid from their body as they should, right? The sodium builds up in the tissues and bloodstream and may cause any one or all of the listed below as increased thirst, edema, which is swellings, and it can be of the hands, it can be of the face. It can also cause the blood pressure to increase. It can cause heart failure because the excessive fluid in the bloodstream can now overwork the heart. It can also cause shortness of breath, because when the fluid has nowhere to go, guess what happens? The fluid starts to settle in your lungs and you start having pulmonary edema. And now, because that fluid is built up in your lungs, you can no longer diffuse oxygen into your body, and now you have shortness of breath. and it proves very difficult for patients when they have fluid on their lungs. Sometimes they have to sleep in a seated position, because when they lie down, the fluid covers the majority of their lungs and they feel like they are drowning. Potassium,
Wow.
it's an important mineral found in many foods that we eat in the body. It plays a role in keeping the heartbeat regular and the muscles working correctly. Potassium also is necessary for maintaining fluid and electrolyte balance as well. And the kidneys help to balance the amount that is necessary. However, again, we're going back to the fact that the kidneys are not excreting things the way that it should. Now, what can happen when the kidneys fail and no longer remove excess potassium? Well, we can have muscle weakness, we can have irregular heartbeat, we can have a slow pulse, we can have a heart attack, and even death. So what happens is that we have to tell the patients now that they have to go through all the nutritional values of the foods that they eat, and we need to start cutting things out that are high in potassium. And Ingram, I'm telling you, it's unfortunate for the patients in Grenada, because the majority of Caribbean or tropical foods are high in potassium. So for example, let's say the provision, yams, potatoes, dasheen, plantains, what else, eddos, all these things, high potassium. What else again? The mangoes, the bananas, the papaya, the oranges, high in potassium. So what has to happen now is that they cannot, let's say for the starchy foods, what they can do is that they will have to prepare the food differently. They'll have to divide the food up into smaller chunks, and now they will have to put that in some water, soak it probably overnight, or they will have to start boiling it, throw the water out, boil it again, throw that water out, and then cook the food in their meal. That way that the potassium can be leached out of their food. So you find a lot of patients complain, oh my goodness, it's mango season like now, and I can't have a mango. I love papayas and I can't have papaya. I love orange juice and I can't have orange juice, because like these foods, you can't leach the potassium out of them. So you have to avoid it completely. And most importantly, because they are high in potassium, you stand a chance of disrupting the function of your heart and could lead to a heart attack and even a death. So we have two others, but I'll give you time to interject here.
Okay. Were you going to say something?
No, go ahead.
I was going to say to you, Daniel, that for all the years you're taught growing up as a young person, fruit is good for you, fruit is good for you, fruit is good for you. It's banged into your head that fruit is good for you. Now you're going to a hospital and you're getting treated at the clinic. The clinic's telling you, well, no, you can't have that, you can't have this. But I thought fruit was good for me. No, not for you. No, not my friend. It's not happening. How do you deal with that mental breakdown now? Because you've been taught something for 40, 50 years of your life, and now you're being told, well, sorry, you can't have that no more.
Right. Well, part of the heart is what we do the most, and I'll let Miss Hopkins jump in there as well. But it takes time. Honestly, that's.
Oh.
Yeah.
And you there?
Yes,
I'm here.
Okay.
Sorry.
It takes time, because as a nurse, having to tell patients what they can eat and what they cannot eat, even what is very painful, they love coconut water. People love coconut water. But now you have a kidney problem, now you have a heart problem. You cannot drink coconut water because coconut water is very high in potassium. So most family, as you know, bring coconut water to the bedside for the patient. Now you're telling the patient they cannot have coconut water. Now you as a nurse have to really sit and explain to that patient why you cannot have this. When you are healthy and your kidney was functioning well, you can have anything you want to in moderation. But now you do not have a healthy kidney, and you need to live a life now that is something that is not life-threatening. You have to live a life now. If you want to live, you have to comply with the diet that you have, but it's very hard. The patient said, my God, it's so hard. I cannot have this. I cannot have this. What I'm going to do, as Daniel said, do you want me to eat grass? No. But it's a mindset now. The nurse and the dietitian, that's where they come in. Not even the doctor, but the nurse and the dietitian have to spend time with that patient to let that patient know the reason why. You can have a heart attack if you have too much potassium. What potassium does, because irregular heartbeat, too much low potassium and too much potassium cause irregular heartbeat. You can go into fibrillation. You can die. So therefore, you have to, and we have to start up, insist on the patient and educate the patient. It's a daily struggle. And if even when the patient leaves the hospital and on dialysis, we have to struggle with that patient to let that patient know, that client at that time knows why those things. We have to show you them diagram. We cannot just say, don't do this. We have to show them why. We have to show them somebody with a heart failure because of the potassium. We have to show them some, so we teach them both visual and orally, verbally, so they can understand. Because it's not an easy thing to have kidney failure. This is why our job as a kidney foundation is education, education, education.
I'm going to skip a point, and I'm going to try and jump, if I can, to, okay, this is my situation. I've got renal failure. I have to come and see the Grenada Kidney Foundation. I have to come to a clinic. I have to get treated. Okay, so can we skip to the point of I'm at the clinic, or I'm about to come to the clinic, the services you offer and the process? Can we jump to that? Is that possible?
Yeah, yes, we can do that. Not a problem. So I'm going to open back my presentation again, and we're just going to jump.
So if you get your presentation done, I think Ms. Hopkins wants to say something while you're.
Okay, yes, there are several procedures. One, the doctor says to you, you have kidney failure. You need to go on dialysis. There is just several process. You have to first get an access. You have an access. I mean, you got to have a vein and artery working properly. You have to have the access put in. Emergency, they put it into your neck. It's a long catheter that is put into your neck or into your groin. That costs about $4,000 just to put in this catheter. That's the preparation, first of all, before you can even attempt to have dialysis. And once you're having dialysis, the cost of it is like $695 one treatment. You need 3 treatments per week. That is 12 treatment at $695 per treatment. The cost. If you have to have a shunt, the shunt or the fistula, which is they take a vein and an artery and tie them together, sew them together, so they can have a passage to have the dialysis. That's $10,000. So we try to tell people, well, you're burying your feet. We try to tell people the cost, financial cost, and the financial burden of the cost of dialysis before they even have to have the procedure done.
Now, Daniel's got a presentation for us, I believe. Daniel?
Yes.
If I go to that presentation now, if you get your screen up.
Yes, go ahead. Yeah, go ahead.
Okay, let me bring that up. Okay, here we go.
Right. So as Ms. Hopkins was saying that, as you were asking, so okay, so what do? We have a patient now. They're in stage 5 kidney failure. They have to receive dialysis there at our clinic. So what we have to first do is basically explain to them what dialysis is. And dialysis, just in a nutshell, as we're going to go through, it's basically artificial. It's like being an artificial kidney for that patient because their kidneys are not working. Right. So basically, dialysis takes over the function of the kidneys. As you see here, 2 very sad kidneys are saying that they failed their report card because they are not functioning. So now we have to be artificial kidney for those patients. Now there are 2 types of treatments that is offered, and these are what you would call intermediate treatments, basically, which are hemodialysis and peritoneal dialysis. Now, hemodialysis, as in breaking down the word hemo, meaning blood, and peritoneal, meaning referring to the peritoneum, which is a space between the abdominal muscles and the lining of your organs within your abdomen. So those are the two types of hemodialysis that we have. However, at our clinic, we do hemodialysis, and the peritoneal dialysis, we do have persons who do it in Grenada, but they do it at home. So the difference is that with the hemodialysis, your blood is passed through a filter with a machine, and that is cleaned. And what you say is like it's cleaned actively. There's a pump that pumps your blood, passes it through a filter, and that helps clean the blood. Peritoneal dialysis, we use somewhat of a similar fluid that passes through the hemodialysis filter, but we infuse that into your abdominal area, and we leave it to sit there for a while. And through a little bit of chemistry, osmosis, and diffusion, those contaminants that are flowing in your blood, because there are so many small blood vessels in your abdominal cavity, they can passively come over into the fluid, and then eventually that fluid is drained. So we spoke earlier about who needs dialysis, and we already said that if you are in stage 5 kidney failure, which is 15% or less of the GFR or the glomerular filtration rate, then that patient has to start kidney dialysis. And here you see a small diagram of those tiny blood vessels. When they get damaged or so on, for whatever reason, those no longer are able to pass blood through them, and the filtration decreases. So here again are just an illustration of the different levels of chronic kidney disease. And right now we are dealing with that little destroyed robot over there who seems to has all his wires twisted. This is a patient that we're dealing with right now. Right, so let's talk about it. We already spoke about the fact that the kidneys maintain the overall fluid balance, minerals. So we have to explain this again to our patients. We also have to tell them the functions of the kidney, and that the kidneys is responsible for cleaning the blood, for filtering minerals, for filtering waste, and also for producing hormones that promote healthy bones and regulate blood pressure, and also to promote the production of red blood cells, right? So hemodialysis pumps your blood through a dialysis machine, removes excess waste and fluid. This filter passes through, we call it a dialyzer or an artificial kidney, right? The blood is then returned to your body, and more is taken in a continuous loop. So we don't remove the blood and then process it and give you back. We usually it goes in a continuous loop. Average treatment takes 3 hours. For most patients. We have patients that have to do it 4 hours or 4.5 hours sometimes, especially very large patients, and it has to be done on average 3 times a week. Here's an example of what a dialyzer looks like, and you can just imagine holding a bunch of straws, and imagine that the blood is passing on the inside of the straws, and those are the spaces that you see between the straws that you're holding. The outside, there's a fluid that passes there. Now the blood and the plasma and other things cannot pass through this membrane, but the solutes that we want to get out, which we will consider waste, are able to pass through. So we pass the blood going one direction, and we let the fluid pass through the other way, and slowly we are able to take fluid and the waste out of the patient's blood. And just an idea of how that works again. We are moving minerals from a high concentration to a low concentration. Just elementary chemistry here, very simple, although it seems complicated to some. Also diffusion, moving from a high concentration to a low concentration, and also ultrafiltration, where you have something is moving across a membrane because you're putting pressure on one side. This is an example of a dialyzer. It's very simple. It's about, it looks big on the screen, but it's actually average about 12 to 14 inches long by maybe.
Feels like an injection.
Sorry?
Looks like an injection.
Like an injection. Well, yes. Well, it's just it looks sort of big, but it's just about 12 inches long by about 4 inches, 4 inches wide in diameter. So just imagine a cylinder with a bunch of tiny, tiny, tiny straws packed inside of it, right?
Right.
So as Anne was speaking about, how do you get onto the machine? And this is where problems, well, it starts to get quite expensive. So now you have to find a way for us to get to your blood. And there's 2 or 3 main ways that we can get to your blood. One, through a fistula, or arteriovenous fistula, and Ms. Hopkins had explained it to you, where you'd attach a vein and an artery, and we're able to, that causes the vein to swell up over time, and we're able to stick you with a needle. That's a surgery, an invasive surgery, and it costs quite a bit, and it's very expensive. And although it's sort of a similar, a simple procedure, it can come with complications. There's also a graft, which is similar, but we just use a synthetic piece of material like polyurethane, something of that sort, that is non-cryogenic, or meaning it does not cause allergic reaction. And you join one into an artery, one into a vein, and we stick the needle through your skin to get into that graft. Also, which is most common when patients now start, we call a central venous catheter. And what they do primarily is that they send a catheter through your chest, under your skin, just above your ribs, and it goes up to your neck, most of the time on the right side. And they send this very long catheter that's about 12 to 16 inches. They send that through your jugular vein and down just to hang just above your heart. So none of them are very pleasant to have happen, but unfortunately, that's the only way we can get adequate blood flow, right? This is an example of what a graft versus a fistula looks like. So on the top right, you can see the blue represents venous and red represents arterial, and they join the artery to the vein, and this causes the vein to swell up quite big over time. Then in the bottom, you can see where they take a graft, a piece of synthetic material, and they join them. And in this case, we will use the graft in order to connect the patient to the machine, right? This is an example of what the catheter looks like. It goes through your skin, into your jugular vein, and down to the top of your heart. It's a very painful process because they don't usually put you on anesthesia for it. So they have to poke your skin, get into your vein, and fish those lines into your body.
Oh, Lord.
This is an example of what a fistula looks like. I'm sorry. I'm sorry if anybody's screaming.
It's good, but it's good. It's the visual effect is oh.
All right. So on your left, you see what a arteriovenous fistula looks like. So now that you can see the person's vein has...
I've got to change my diet. I changed my diet.
Sorry, I'm sorry.
Ms. Hopkins, right? I changed my diet now.
It's important. I'm very happy that you are looking at this and you understand the consequences of living a good and healthy lifestyle.
Can you bring that picture up again, Daniel? Just that one again. That it paints such a picture while Miss Hopkins is talking. Go ahead, Miss Hopkins.
Yeah, this is why lifestyle, changing of lifestyle is important. So now you see the consequences of bad lifestyle. Alcohol drinking is another cause of kidney failure and kidney damage. Too much over-the-counter medication, too much sugar, too much salt. So now you see your lifestyle and it's changing, and this is where teaching come in. And I'm glad you notice the outcome of bad eating habits.
Yes, that picture, it speaks 1,000 words, Daniel. You know, it speaks 1,000 words. You know, it pictures like that just ram home exactly why we need to change our diet.
Exactly.
Before, all you were talking was some nice words and some words I didn't understand. But all the stuff you were talking before sounded very nice. It sounded, you know, the different terms and terminology sound very professional and stuff. And I was in my comfort zone with that. But show me that. It makes it very clear. Very, very. I think our viewers would say it's very clear as well for them to see.
Right.
Do you have any more pictures like this, Daniel, along the way?
We can continue the presentation just to get an idea, and then we can continue. I won't, yeah, if you like.
Keep going, Daniel. Keep going. Keep going. Tell him to stop you.
Okay. Just go ahead and mute. Right. So on the left we have a fistula, and as you can see, the veins are engorged quite a bit. This allows us to put 15 gauge size needles in your hand. If you want sort of a reference, usually when you go to take your blood, they will use anywhere around to a 21 gauge. Now, the lower the number, the larger the needle. And you usually use like a 21 gauge to a 23 gauge. We use 15. So you can actually look down the bore of the needle. That's how big it is. So that allows us to get adequate blood flow so that we can give the patient effective dialysis. On the right-hand side, you can see a catheter that's placed in the patient's chest, and there are two legs on it, and blue and red, sorry, to indicate the arterial side and the venous side, right? This is a diagram of how we run the blood through the machine, or I should say through the filter, back to the patient. So the blood is just drawn from the patient's arm. We have a pump that pumps the blood. It goes up. We have some monitors that helps us to be able to make sure that we're performing safe dialysis. The blood passes through a dialyzer. And if you notice the blood is coming out red, that's just to indicate that it's unclean. It goes through the dialyzer, and as you see that it's coming out of the dialyzer, the blood is coming out clean, meaning that it's filtered. It passes through again, going over now to the right, top right, passes through some other monitors to make sure that it's safe before it returns to the body, and then it goes straight into the person's bloodstream. So we create a continuous loop rather than removing, as a concept some people may have of removing the blood from the body and then returning it to them. We create a continuous loop. So we call it an extracorporeal circuit. So we're creating a circuit of your blood to pass through while it's being filtered. Now, this is what an example of a dialysis machine. Actually, this is one of our machines, and this is what a hemodialysis machine looks like. You cannot see the patient off to the side on the right side, but if I were to work my way from the right, you would see that long thing that's being held there. That is the dialyzer, and you can see the blood tubing. One blood tubing passes half across the dialyzer and goes over to the left. It goes into the first chamber. From the chamber, you see a device there with something that says 255 and a big box on it. That's the blood pump, and that continually spins in order to push the blood. We go across to the next segment, and there's something, a heparin pump or a medication pump to slowly infuse medication during treatment. Then the last segment is the venous air chamber, and that's just to make sure that there's no air in the line before the patient goes back to the patient and then it returns to them. So we have several different sensors, and if this works, we should see it running here like that. All right. So you can actually see the pumping, and it's very anticlimactic, but it gets the job done. Right? Is it painful? Now, the short and long answer of it is yes and no. So the insertion of the needles, if you have a fistula, yes, it's painful as any other injection would be. It may be slightly more painful, but some patients, or a lot of patients, says it feels the same way as receiving a regular injection or having your blood taken. So we try to make sure that patients stay calm and relaxed, and we insert the needles into the patient's vein in order to perform the treatment. Peritoneal dialysis, there is no painful side effects to it. It's just infusing the fluid into your peritoneum, and all you get is just the sense of weight or heaviness around your abdominal area. So there's no pain involved in that one. And here's another example here, the peritoneal one, where the fluid is just infused into the stomach. And as you see, the dialysate bag that's over on the right side, you see it's clear and it's infused into the body. But if you notice, the fluid in the stomach now looks almost like urine. And that's exactly what's happening, is that it's pulling the same waste that your kidneys will pull out into itself, and now it's actually creating sort of a bag of urine that's in your abdominal area. And then we let that stay there for anywhere from 2 to 4 hours at a time, and then we drain it out. And it also brings along extra fluid with it, right? This is what a peritoneal catheter looks like. It just looks like a tube hanging out of your stomach, but instead of going into your stomach itself, like your gut, it actually stays between the layers of your organs, your muscles and your organs actually, all right? Side effects of dialysis: low blood pressure, nausea, vomiting, dry, itchy skin, restless leg syndrome, muscle cramps. Low blood pressure because we're removing fluid from the person, and sometimes we can have what you call hypovolemic shock. Hypo meaning low, volemic meaning volume, and shock occurring from that because it causes your blood pressure to drop. Nausea and vomiting, sometimes just the body tolerating the treatment. Dry, itchy skin because we're constantly removing fluid from them, and also because of the phosphorus and other issues that they may have, you tend to get very dry, itchy skin because of the high urea content in their blood. Restless leg syndrome, it's just something that doesn't happen to everyone, but the patients are always usually uneasy. They can never find a comfortable position at times. Muscle cramping because we're pulling fluid out, but in that fluid, salt, potassium, other things are coming out, which are important for muscle function, and sometimes you end up cramping up, all right? Anemia complications, we deal with anemia because the kidneys are not working. So the kidneys are not triggering the body to make red blood cells. And every time you do dialysis, there is a small amount of blood loss in the lines when you finish treatment. So it can contribute to anemia. You can have too much water or too much sodium and cause fluid overload based on the parameters that you put in the machine. But sometimes if the person is uncomfortable or their body is not tolerating the treatment, we can actually spike their blood pressure or drop their blood pressure. Nerve changes, things like that, skin changes, there are many different things can cause different side effects. Now, can kidney disease be cured? The short and long answer of it is not really. We can stop the progression, but there really isn't any known workable cure for reversing kidney disease, especially when the kidneys are damaged beyond extent. And usually, the only way to come back to normal function would be to have a kidney transplant. And at this moment, I'll ask you a question, Ingram. When a patient does a kidney transplant, how many kidneys do they have? That's a question for you.
They have 2 kidneys at first, but if they're damaged,
right,
then they would have it could be one or both kidneys are damaged. So I don't know how bad the damage would be.
Okay. So how much kidneys do you think they will have if they have a transplant?
Well, I don't know if they. I would assume they could survive on 1 kidney.
Right.
So,
well,
yeah, transplant means none of the kidneys are working.
Right. So usually persons might think that when kidneys are not working, that we remove the kidneys from the body. But actually, if the kidneys are not a threat to your life, like for example, the kidneys is not cancerous, or the kidneys is not causing some fatal problem to you, then actually we leave those in there and we add a 3rd kidney to your body.
Wow.
So if somebody has a kidney transplant, they will have 3 kidneys once the other 2 have not been interfered with. So that's just a little did you know fact right there.
Well, now I know. Larissa determined says 3. Well, yes.
Okay.
Wow.
Right.
But can I also add something?
Go ahead.
Some people, some babies are born without kidneys. Some people are born with 1 kidney, some with 2, and also some with 3 kidneys. So we can also have that combination of kidneys at birth when someone is born. And also reversible kidney disease, the only time you can reverse the kidneys when they're damaged is to if they're in an acute stage. If there is an acute stage and it's not something that really damages the kidney, the person have an accident and they bleed a lot and the blood volume drop, they can cause the kidney to stop functioning. But after a few treatments, the kidneys can come back working. But once it's a chronic condition, the kidneys are not restorable. But in an acute situation, like an accident, or you take an overdose of medication and the kidneys will slow down, you can reverse that part if it's acute. But once it's chronic, it's not reversible.
Okay. Question. What about people with alternative medicine and would be using herbs and stuff, or would say, well, we can reverse the process? Is that process reversible, or be able to maintain or to stop the kidneys worsening? So if they can't reverse, they can just maintain. What about that, Daniel or Anne, or both of you?
Go ahead, Daniel.
So what I usually tell persons is that modern medicine comes from natural medicine. So there is a likelihood that the same forms of medication in the natural setting can contribute to slowing the progression or even halting the progression of renal failure. However, because we are not doing so much research or just because of how we've become so modernized, a lot of the research that are based on the natural herbs that we take, some persons, they're taking it with just hearsay. I heard somebody said this is good for your kidney. I heard somebody said that is good for your kidney. And just to put things into perspective is that almost every medication that is good for your kidney, if it's taken in the wrong dosage, especially on the higher side, will actually cause twice the amount of damage that would have occurred. So let's say you want to go the natural route, and maybe there are some things that are that can help your kidneys, but sometimes we take it to the extreme, right? For example, I'll give you a natural remedy here. Persons who have kidney stones, you can use the silk of a corn. So you can get the natural corn, you can take the silk, and we can actually draw it like a tea, and the compounds of that will actually help to dissolve the kidney stones and help you pass them. But at the same time, some people would be like, all right, well, if they said a handful of the silk once a day, you're going to do it, all right, well, maybe if I do more, it's going to be better. And a lot of times we are not able to measure and to gauge how much we are receiving. So it's a very tricky balance, but I do believe in natural remedies as well, but it has to be done on a very controlled setting. And I would always advise that persons still seek advice from their medical practitioner as to if what they are doing is safe or if it's going to now contradict what it is that they are planning to take. Because doctors now are becoming very honest, and they are actually telling you that, hey, yes, you can try this. You're not in a stage for dialysis. There are certain things that I feel safe with you going ahead and try, and others, no, I don't.
I must say one thing also, that to measure the values of the leaves we do use, we can't really measure the values and the amount we are taking if it's right for the kidney. We also have to remember that the kidney is the one that function and remove waste products. Now the kidney is unable to remove these waste products, and if you take too much of these waste products, what happens? It's accumulate in your system, and it causes more damage, more harm than anything else. Another thing, once the kidney is dead, the tissue is dead. The tissue become necrotic meaning dead. How can we reverse a dead kidney? And I always look at it that way. All right, you take this, your kidney is not functioning, 95% is damaged, it's not functioning. How can you, and all the research they have done many research, England, Canada, Ireland, America, they are trying to see if they could reverse kidney disease, but it has not yet been possible because that kidney is dead, it's necrotic, there is no blood vessel, there is no ending.
Let me throw this at you, Ms. Hopkin. Now, critics would say that pharmaceutical companies would not produce cures because if they produce cures, then they'll be out of business. So they've got to keep people coming back to them over and over again. If this is the case, then doctors can't cure but kill. That's what they will say. The critics will say that.
Yes. The
Kill,
critics
but can't cure but kill, right? We still have not found the cure to the common cold. However, there are, if we eat healthy, if we keep ourselves less stressed, there are ways we can combat, and at least prevention is better than cures. They would, as you would rightly agree there. However, if there's a way that we can maintain, even if it's damaged, we can maintain. Would the medical profession be honest enough to say, you know what, you can avoid this dialysis by drinking this or eating this or doing this? Or is the medical profession more likely to say, you know what, we can't help you here, you have to go for dialysis because it helps our economy or it helps our system, we can get more money from it? So that's a question I've got to ask.
Yeah, very few doctors will tell you the truth. I mean, some doctors will, but some again. And some of them, you know, the medication companies that pays big money, you know, samples here and samples there. We're not going to say the medication companies.
Yes.
We're not going to give you the right, in my opinion.
Yes.
Because they want to keep making money, like the expiration date on the medication. Some of the time the medication is quite okay. You can continue taking the medication, but they put an expiration date. So whereby at that time, you have to buy new medication. But I'm going, you understand, but I'm going on the fact that a dead thing, a dead tissue, a dead kidney. I can see you taking medication, you're quite right to maintain it. But after you pass stage 4, the kidney is dead.
Well, usually when something is dead, usually there is no medication, bring it back alive. Usually
yes.
It's finished, means coughing, means burning, means kaput, no more.
Yes. So if you say at stage 4, before stage 4, I can, under controlled circumstances, you can take this medication and the herbalist will, and then you can maintain. But after stage 4, we know scientific research and data has said that your kidney is dead, and we know by research and by looking at it and working with the patient and looking at the results, what happens? High creatinine, high bone, high potassium, calcium. The kidney is dead. Is unable to function to get this out. So I can see myself before stage 4 with diet and medication maintaining. But after stage 4, after all these hundreds of years, since they found out, I think it's the 15th century, they start playing at the 17th century with dialysis to get the kidney functioning. They have reached to the stage where they know at stage 5, your kidney is irreversible. The damage done is reversible. But new research is going on now. So by stage 1, 2, 3, and 4, to see if they can really keep that kidney alive and prevent you from having the dialysis.
Yeah, absolutely. Daniel, did you want to add to this?
I was just going to put in there that I actually, just to put it into perspective, that I have patients, okay, Yeah, so just to put it into perspective, I have patients that do not produce any urine. I have patients who don't remember the last time they produced a drop of urine. Now,
Excuse me?
yeah,
A drop
so
of urine.
they
How's
they
that
don't,
possible?
because their kidneys are no longer functioning whatsoever. So they have two kidneys, but they're gone. So take that into perspective in the case of trying to get a organ to be rejuvenated. The organ is on the outside, the blood goes on the inside, but you would need to rejuvenate both the outside and the inside of the organ. So if nothing can even pass through the kidney, how can medication and other things like that get into the kidney to rejuvenate it if it's completely blocked? So that just puts a perspective on as Ms. Hopkins was saying, that once the kidneys are shot, unfortunately, we currently do not have any research
Solution.
data to come to a solution to that except for transplant. But I'll say this openly, that I'm a believer in God and I believe in miracles. And I
Yes.
think that basically it would have to come from that point of view.
It'd
That a
have to be
miracle,
divine intervention.
there we go, basically.
Can I give you? We really,
Go ahead, Ms. Hopkins.
we really do need some funds and some help, because as you know, it's very expensive, even getting the shunt and the fistula or getting the catheters put in. That costs, $10,000, $4,000 to $10,000. So we're asking anyone who hear us that we have two bank accounts. One is at Cooperative Bank, and the telephone number, the bank account number is 450-574 400000574. That's Cooperative Bank in Grenada. Republic Bank in Grenada, the number is 911-87912. Republic Bank, 911-87912. And also we have a thrift store that people can donate clothes and food stuff we can sell to help the dialysis patient. The thrift store number is 414-37534-1959. 534-1959. At the moment,
calling outside of Grenada, that would be +473. That would be the code.
Yes, 1473.
Correct.
Yes. And also, I can tell you, we have now 18 patients. We have 22 patients in all. 4 has PDs, and then 18 is hemodialysis. And you know how much it costs for to 900 let me see, 690, say $700 times 3, 3/7 is 21, and times 21 times 4, 21 times 4, that's 8, nearly $9,000, $10,000 a month for dialysis. So we are asking, we are begging practically.
So I do, before you go any further, I just want to make it clear, because and I did want to get to this near the end, but COVID-19 and the impact that has had on the dialysis center and the Kidney Foundation, how has COVID-19 and this world pandemic, how has this affected the Kidney Foundation and Grenada on hold? Daniel, or together you could jump in and then we can talk also about obviously this funding that is definitely necessary and how we need to raise funds for the Grenada Kidney Foundation.
Drastically, we have to refund our donation drastically. We have boxes all over the places, and now we go to the boxes and the boxes are empty. We have very few people now donating because of the issue with COVID-19. No one knows the future. So everyone is holding back because they do not know what tomorrow will bring. How long will it last? Where am I going to have my resources? I am not working anymore. I'm out of a job. Am I going to get my job back? So that curtail the giving, the free will of people giving. So that have affected us very, very much. Now we have 3 new patients coming on board. We cannot anymore take them, accept them, because we have no funding. We have no money to fund them.
So, of course, people will ask the question of the government, as they will do. How is the government working with the Grenada Foundation, or are they working with Grenada Foundation? How much have they been able to help? Daniel, I'm going to come back to you about this again because I asked you about it last time.
The government gave $1,000 per month per patient. So we have 18 patients, and the government gave us $18,000 per month. And we try to give the $700 and the $695 per month to help the patient. So between the government and the Kidney Foundation, a patient gets $1,700 per month from the foundation and the government. And
where's the rest of it? How's the rest of the money being made then?
The patient have to try and seek the rest for themselves. For some of them, I think 2 or 3 of them have insurance. 2 or 3 of them have insurance that pays for what the patient would. So Trevor is being owed a lot of money, because most of the time the patient comes and they're unable to pay. And what I feel, the family is not really coming forward as they should. I don't know the reason why. Sometimes we have meetings and they do not show up. So I don't know, sometimes they're discouraged, sometimes to see their family going through every day, every other day. It's a day in the life of a patient. I think is horrible. This is why compliance with diet, with medication, do not get yourself into falling into the crack of having kidney disease. You know, it's preventable. So now we are giving a breakdown of the cost and the pain and the suffering it costs, so people can understand that they have to take care. Kidney health is very important. We also have to remember too that apart from kidney dialysis of kidney patient, we have dialysis. We have a patient with high blood pressure. We have patients with diabetes that lend to kidney disease, and then the government. Most of the medication is free. When you go to the clinic, most of the medication is a penny, you know, very free. So the government have all that to do. The government also have cancer patients. The government also have sickle cell patients. So it is not kidney patient alone that the government, a whole range of other chronic diseases that have to be funded. So it's very difficult, very difficult.
Thank you, Ms. Hopkins. Daniel, did you want to close up for us, please? Thank you, Ms. Hopkins, for your contribution. Appreciate it.
And thank you for having me.
Yes, so yeah, just based on your last question again, and I'm going back to the same thing that I said before. The Kidney Foundation is struggling, obviously, and not only that, but we ourselves are struggling to keep the price the same. Because of COVID-19, the price of the medical supplies have gone up by 20%. We get our supplies from the US, and because the US is trying to make sure that they are trying to safeguard their future, they are trying to increase the price to reduce the amount of supplies leaving their country, even though they are still open for trade. So it is proving to be quite difficult. The government has given their word that they're going to do their best to assist. Since our last meeting, I did mention to you that it was stated that the government is going to reestablish their dialysis program, and they should have a dialysis clinic up and running. The timeline that was given to us from the time I spoke to you would have been 4 to 6 weeks, and I think we're just within that window. We have not had any public update in regards to that. Which is understandable because of COVID and so on. But it is a challenge, and even though we are a private entity, we stand hand in hand in solidarity with the Kidney Foundation, with the patients, with the family members that are affected. and we ourselves are advocating for persons to come out to assist in whatever way they can. I know that the economy has damaged a lot of what has happened with the economy, but COVID-19, humans are resilient and we will overcome. And I think that we should have that mindset that we are going to overcome. How long is it going to take? We are not sure. And to be honest, we are never sure of what the future holds. All we have is now. So if there are persons who have put things aside for things that they probably don't need versus they want, and they wanted to put towards a better cause, then get in contact with us, get in contact with the Kidney Foundation, get in contact with the clinic if you're a medical person listening to this who is affiliated with a dialysis clinic or access clinic, things like that, and you can donate things like dressings and catheters, bandages, whatever it might be, dialysis supplies, then feel free to contact us and have those things donated, because every little drop counts. So again, I would like to thank you for facilitating us, and I do hope the message continues to go out, and I hope people understand how severe kidney failure is and how much it can affect your life. And just even to put that into perspective as well, imagine having COVID every day of your life. And so it's like you don't know what tomorrow brings. Every day is, shall I live to see tomorrow? Shall I have the finances for tomorrow? Shall the clinic have the supplies for tomorrow? So it's mentally taxing, it's financially taxing, it's socially taxing. So whoever can, please assist. And you yourself, I want to commend you for all the work that you're putting into getting our voices heard for the patients. A little adds to a lot, and I really do appreciate that on behalf of the patients. The patients, from the feedback, especially from like the last meeting that we had, they were very ecstatic. They were very pleased to know that we are going international, and we're reaching out. I mean, after the meeting that we had, I believe there was an online concert, and that raised the money. I think that raised almost 2,000 US. So people are out there and they're trying. Yeah. So we really do appreciate that, and we appreciate you for all your hard work as well to put your attention to things like this, you know. Absolutely. So I just like to say thank you.
Thank you. I want to say to anybody that's watching this stream, watching this, whether you're watching on YouTube or you're watching on Facebook, please, even if you cannot financially support, your support by just sharing this video on your page, there may be somebody out there that can support us. So, and support the Kidney Foundation. So please share this video wherever you can. In any group you can share it, please do, because your help does matter.
And thank you so much. Thank you so much for having us. Thank you so much for trying to help us. Thank you so much for getting us on the road, for getting us on the map, for letting people know that we have a Grenada and the people do care.
As I say, don't look at me, look at God. That's what I always say.
Thank you.
Okay, that is it from us at BWTM. Thank you so much for Daniel Richardson, of course, Miss Ann Hopkins. Thank you both for being part of this show, and to you, the viewers. Please, we ask if you cannot contribute monetarily, we ask that you contribute by just sharing this video on your wall across groups. Content capital is crucial. Thank you so much again. This has been BWTM Online, and we're out. Thanks for watching.